So chapter 12 is antimicrobial therapy, and this is almost like pharmacology. Did you guys do pharmacology before? Okay, so it's kind of pharmacology, but I'm going to focus more on the microbiology side of it. But there is part of pharmacology anyway that we have to do. But again, I'm going to focus more on the part that's related to us. So, as an introduction, the antimicrobial drugs, they come from many sources. Since we're doing the microbiology, we are talking about mainly antibiotics. Antibiotics, antifungals, antivirus, and so on. This is what we're going to be focusing on specifically, or more importantly, the antibiotics. The antibiotics are coming from different sources, can come from different sources. The antibiotics specifically come from bacteria and fungus itself. It can come from bacteria and fungus. And the way they found out that they can use this for humans is they noticed, or they watched the behavior of the bacteria. Like if I have a dish like this and I have multiple bacteria, okay, they notice that some bacteria are growing more than others. So they say, okay, why this is happening? They found out that this is the history. They found out that these bacteria that's overtaking and controlling the medium is secreting something to kill the other bacteria, so they do not compete with this bacteria. Okay? Like bacteria A, type of bacteria, is growing more than B and C. Why? So they found that A, that's growing more, is secreting something. This something is inhibiting the other ones. So there will not be that much competition to bacteria A. And they studied that until they found out that this is actually the antibiotics. It's a chemical secreted to inhibit the other types of bacteria surrounding it. So they said, okay, why don't we take it, and the bacteria that was inhibited, we can kill these bacteria by this antibiotic. So they started to study that, and this is true for bacteria and for fungus and others. This is the very, very beginning, how they did the antibiotics. Later on, they studied the composition of this chemical, which is the antibiotics, and they started to synthesize it in the lab. They started to make it. Of course, what we see, the medications that we see in different pharmacies, is not all coming from fungus and bacteria. Wouldn't have enough, right? So this is called synthesized. It is completely synthesized in the lab. There is the third category that is kind of combination between those, which is they take the antibiotics that's coming from bacteria or fungus and they modify it in the lab. So this will give us the three categories. The natural one, you just took it from bacteria. Is that clear? Just coming from the bacteria or fungus. We'll take it as it is, isolate. The other one is we make it in the lab. The third one is, how about we take the natural one and modify it a little bit in order to give us what we need. Selective toxicity. Anti means against. Biotic, bio means life, right? See, antibiotics means against life. And so when they discovered the antibiotics, they found that it's against the life of other bacteria, right? It's killing the other bacteria. So that's where the name came from. Why did we call it antibiotics? It's against life. Against life of what? Of the other bacteria, right? Which is good. That's not bad. But it should not be against the life of ourselves. And this is what we call it selective toxicity. So it's against the life of bacteria, against life of what we don't want to be there. But it's not harming ourselves. Is that clear so far? How does these antimicrobials, you can call it antimicrobial, germicidal, whatever you call it, how do these stop infection? They are going to stop the bacteria somehow, right? Like they notice that this type A bacteria is stopping the other types. How? How does it happen? It can work on different levels, and we have details to discuss about this. Just take a look at this for now, and you will notice that if this is a bacteria like this, you have cell membrane, and what's unique about bacteria being a prokaryote is the cell wall. Do you remember this? Yeah. Outside of the cell membrane, unlike our cells, we do not have a cell wall. Eukaryotes, most of them do not have a cell wall. Bacteria does, being prokaryote. And being prokaryote, what we don't have? The nucleus. But do they have genetic material? Yeah. Yes, but not inside a nuclear membrane, right? So they also have some ribosomes, but they don't have the rest of the eukaryote structures. So the antibiotics will work on one of those, what you see here in the picture. Can work on the wall, can work on the membrane, can work on the ribosome, it can work on genetic material, whether it is DNA or RNA, and we will discuss that, but this is basically, as an introduction, this is generally speaking how they work. If this antibiotic is selectively toxic to the microbes, to the bacteria, we call this selective toxicity, right? So if this type of antibiotics is toxic and it's against the life of other bacteria, not ours, this is good, right? But even though it does not kill our cells, but is it doing some harmful effects? It's not killing it, but can we have other things besides? It's not killing, but can we have something else? Yes, we can have other side effects. We can have something like allergy. It's not killing, right? So it is selectively toxic, but it can cause allergy, for example. It can cause other reactions. One thing that's important to know is, do we know that we have a good bacteria in our gut, in our intestine? Yeah. We do have good bacteria, right? And we call it the normal flora. This is something that you have to have. It's not only that's not harmful, it's actually beneficial. The best example of that is vitamin K. The vast majority of vitamin K come from bacteria in our large intestine, right? Yeah. Besides, here is the most important part. Why the normal flora is important for us. We have number of bacteria in our large intestine, let's say, or in our gut in general, right? These bacteria have a balance between them. So if a harmful bacteria came, it will only compete. It will compete with them, right? With the bacteria that we have. So it will not be easy for the harmful bacteria to take over, because there is a competition. But the problem is, if we are using this type of antibiotics that kills our normal flora, and now you're having this type of bacteria that does not have competition, is it going to be stronger and more harmful? Does it make sense? So under normal circumstances, if your normal flora is working just fine, you have different types of good bacteria, if a bad bacteria come, it will compete. So you're kind of resisting, right? You're competing with your bacteria is competing for you, right? Of course, the bacteria is doing that for itself, but it's protecting us at the same time. So having a competition is a good thing. But if you take antibiotics, specifically the broad spectrum, and we will talk about the details, but if you're taking broad spectrum antibiotics, it will not only kill the bad bacteria, it will kill your good bacteria, your normal flora. So if a bad bacteria come, there will not be that competition, and they will take over, and it will be a lot more harmful. The other issue with the different medications is the drug resistance. We hear about that all the time, to the extent of they stopped some antibiotics. They said, we're not going to use this antibiotic anymore. Why? Because of the drug resistance. Some bacteria are resistant to drug. And they stopped giving these types of antibiotics to this type of bacteria. In medical school or nursing or whatever you're doing, they will tell you that you cannot use this antibiotic for this bacteria. But we used to use it, like 30 years ago. We used to use it. Yes, not anymore. Why? Because the bacteria now is resistant. How the bacteria become resistant? It was okay before and now it's resistant. It was okay. It was sensitive. What happened? A lot of things can happen that the bacteria become resistant. They can change their genes. Not intentionally, it just happened. Spontaneous. Like something happened to the gene, they change, and the medication is not effective anymore. Some bacteria, they found out that some bacteria will release enzymes to break down the antibiotics. Okay? And here is exactly the history. So just understand this. Here's what's happening. I'm giving antibiotics that's killing the bacteria and everything is fine. Okay? That's in the history. Everything is okay. Giving bacteria, patients are being treated and everything was going fine. Okay? Until some of these bacteria, they have spontaneous genetic mutation or something, or others that are secreting chemicals, and those only few, they started to resist, okay? But you're still calling the vast majority. So the vast majority are killed and those are staying. And those who stayed and have this good ability for them against us, right? If they secrete that chemical, this is bad for us, but good for them, right? So those who stayed are going to exist. Not only exist, they're going to replicate and reproduce. So what actually happened is you're getting rid of the sensitive bacteria, you're wiping them off, and the other ones you cannot do anything, so they flourish, and this is the one that we see now. For this type of antibiotics, so they change the antibiotics later. There are different ways that we will see which is which. If you are going to choose drug or antibiotic in this case, what should you put in mind? And this will be useful later on if you're like doing nursing or you're going to be studying pharmacology, and you need to understand how to choose. What's the most important thing? The nature of the infectious agent, like what type of bacteria is that, so I can choose a good antibiotic for it. This is one. I need to know if this bacteria is sensitive to the drug that I'm going to do or not. What kind of side effects is it going to do? And what kind of a patient? Is the patient healthy, young, or old? Or does he have a disease that can be, or a condition that will be affected? So this will all of this, we have to put it into consideration when we choose the appropriate antibiotic. So generally speaking, the antimicrobial chemotherapy is supposed to, as we mentioned before, it's supposed to be antibiotic to the bacteria, but not antibiotic to us. Against the life of the bacteria, not against our life or our cell's life. What do you call this? If it can kill the bacteria, it's against the life of the bacteria, not ours. Selective toxicity. Selective toxicity. So what's selective toxicity? It's selectively toxic. What do you mean by selectively toxic? It is toxic against bacteria, not toxic against us. Is that okay so far?
Yeah.
Okay. These antibiotics, as I mentioned before, it can be natural, it can be synthetic, it can be semi-synthetic. There is no perfect drug. Like if you say, okay, I'm going to choose the perfect one. This one is not harmful to ourselves, it's harmful to the bacteria, it does not have side effects, does not have anything. No, that's not true. There will be something, but you're choosing the best of what you have. Okay? This is how we choose our medication. There is nothing perfect. So the ideal antimicrobial, ideal doesn't mean perfect. Is that clear? There is no perfect. Ideal means the best of what you have. It should be selectively toxic, obviously toxic to the microbes, not to ourselves. It's better to be microcidal rather than microstatic. Like if I have a choice of two antibiotics, both of them are effective. One of them will kill the bacteria and the other one will, what's static mean?
Stops the growth of it.
Yes, to stop the growth or to slow it down, right? Which one would you choose? If both of them are good, if both of them are okay, both of them are effective, which one would you choose? The cidal or the static?
Cidal.
The cidal, it will kill your bacteria rather than slowing them down, right? If you have the choice. Like if both of them are good, which one should I choose? The one that kills the bacteria, obviously. The other thing is it should remain potent for long enough time until you get rid of the bacteria, meaning if you're using this antibiotic or using this drug, you need to know the lifetime of this medication. How long does it stay? Like I take it and it go to my blood. Is it going to stay like for a couple of hours or is it going to stay for a couple of days? Okay? And how many times should I take it if that's the case? Like, do you know that there are some medications you take it once a day and others you take it 3 times a day, 4 times a day, right? Depending on what? Depending on the potency, how potent it is, how long does it stay. If it stay for a day, I can take it once a day, right? So this is something that we should put into consideration, that it should stay enough. You can't use something that stay less than what it should, and it will not be effective enough. You need to also choose and the antibiotic or the antimicrobial to that microbe that's not resistant. And I talked about this before. If I know that this the best example that they always use is the staph. Do you remember the staphylococcus?
Yeah.
Staphylococcus, there are some strains of those, some type of those are resistant to some type of penicillin called methicillin. Should I use methicillin? Of course not. You know that this is staphylococcus, most likely it's not going to work, right? So this is one factor to choose. You also try to choose a medication that help or complement the activities of the host defense. Something you're using that will work with your natural defenses, right? So this is important to know, and you are going to put all of these factors, 5 factors. You need to put these into consideration when you decide which antibiotic should I use. Or when the pharmaceutical companies try to come with a medication or something, they need to put this into consideration. Is that clear? This is how they choose. Otherwise, it will not be approved. So it should remain active. This is another thing, should remain active and not become very diluted. Like if it is going to be diluted to a certain extent, is it still effective, or it's going to be really diluted so I can't use it? If that's the case, we will not use it. We will not, the pharmaceutical companies will not take a license to produce it, right? They will tell them, this medication that you're giving us and you're trying to get approval, it dilutes very fast. So no, that's not good enough. It's not going to be effective. The other thing is, can it be delivered to the site of infection? Like if I have infection, you're giving me, for example, you're giving me an ointment and you're telling me I'm taking this medication for pneumonia, for example. No. You have to have this medication that go to the site of the infection. Like you're telling me this injection will go to infection in the intestine, for example. I would say yes, okay, that's fine. Or you're taking this antibiotic with ingestion, you're ingesting the antibiotics and it's working on the intestine, or it's going to the blood and this is how it will go. So it has to have a way to be delivered, or it has to have a way to go to the site of the infection itself. The other thing is it also should be reasonably priced. You don't tell me that this medication is an alternative medication that's the capsule is $100, for example. No, we're not going to choose that, right? If you are a nurse or a doctor, you're not going to choose that, unless if this is the only option, right? Which most likely it's not the case for antibiotics. We try to use the one that's reasonably priced. The other thing is we need to choose something that does not disrupt the host health, like it does not cause allergy. You know that any patient, when he go to the doctor, to the nurse, they ask them, do you have any allergies? What's the one that's very famous to have allergy in the antibiotics? Huh? Penicillin, right? They always specifically ask you, do you have allergy against penicillin? So if that's the case, of course, I don't give you penicillin, right? I give you something else, and so on. Antibiotics, as I mentioned before, it's a metabolic product of aerobic bacteria and fungus. They produce it, and I told you how they found out, right? They put the bacteria on a dish and see that this bacteria secreting something to kill the others. What is that something? They found out that this is something, a chemical compound, and we will call it antibiotics. Okay? So it is a natural metabolic product of these bacteria and fungi. All right? Here is an example. Bacteria, Streptomyces. You need to know the names, by the way. This is almost pharmacology, so you will have to know the names. Streptomyces. What's the Streptomyces? This is a bacteria. They found this type of bacteria secrete a chemical compound, okay, that kill other bacteria around it. So the antibiotic, they called it an antibiotic, and they call that antibiotic streptomycin. So what's a streptomycin? It's the antibiotic that's secreted from streptomyces, from that bacteria. Bacillus. They found that the bacteria Bacillus, do you remember Bacillus? Looks like rod-shaped. They found this Bacillus to secrete a chemical compound. So they call it an antibiotic. And what should we call that antibiotic? Bacitracin. Bacitracin. Bacillus. It's coming from the name. The antibiotic that's coming from the bacteria or fungus, it come from the name of the bacteria or fungus. Is that clear enough? The bacteria is called Streptomyces. What should I call the antibiotic? Streptomycin. If the bacteria is called Bacillus, what should I call the antibiotic? Bacitracin. Baci is coming from Bacillus, right? Bacitracin. Others, Penicillium. Penicillium is a mold, which is obviously a fungus, right? A mold is a form of fungus. Do you remember this? So Penicillium is coming from this mold. What should we call the antibiotic? I will call it penicillin. Okay? Penicillin. The other type of mold is called Cephalosporium. What should I call the antibiotic that come from those molds? Cephalosporin. Okay? You will notice that the vast majority of these antibiotics will end with IN. Streptomycin, bacitracin, penicillin, IN, cephalosporin, IN. Okay? It's not that simple, but it will usually end by IN. Okay? So I want you to remember these examples with the antibiotics that come from them. Okay? You need to remember this. Bacteria like Streptomyces and Bacillus. What's the antibiotic? Streptomyces. You will see the names. I'm not telling you to remember it right now, but you will see it. But you have to remember it at the end. Streptomyces and Bacillus are bacteria. Antibiotic is Streptomycin and Bacitracin. Penicillium and Cephalosporium. These are molds. These are fungi. What are we going to call the antibiotics that come from those? penicillin, and cephalosporin. Okay? Can you answer this question for me? From the characteristics of the drugs, which one is not important? E? Yes. Static is not better than Cidal. Cidal, of course, is better. So here are some examples, but I told you the most important already. Okay? Penicillium, cephalosporium, Bacillus, Streptomyces. Okay? Streptomycin is the most important one. Just remember, this is good enough to know. Okay? Streptomyces, like the previous slide, but here's giving you the name. So what do you call, this is a Streptomyces. What is this? Is this a bacteria or mold? This is bacteria. What's the name of the antibiotic come from this? Streptomycin. Bacillus, bacitracine. I'm just showing you this to see the names here that I was just mentioning. Okay? The other two are molds. These, right? Penicillium is a mold. Cephalosporium is a mold. It's a fungus, right? What's the name of the antibiotic that comes from the mold, the fungus Penicillium? Penicillin. Cephalosporium, cephalosporin. Okay? So you see the names here. What I mentioned is the most important, okay? Which is the previous slides. As usual, you will notice that I will focus on certain things more than others. Do the same thing. Focus on what I'm focusing on, okay? I'm giving you the most important of all. This slide is extremely important. Very important to know. Every single one of those. What does it mean? Okay? So we'll go one by one, but you have to remember it anyway. Very important. What chemotherapeutic drug, generally speaking? Chemo means chemical, right? Therapeutic means treatment, isn't it? Yeah. Therapy. So chemotherapeutic drug is a drug that the chemical that's used to treat, or not necessarily treat. It can be used as prophylaxis. What's the difference between treatment and prophylaxis? Yes. Treatment is you are sick already. You have the infection, I give you treatment. Prophylaxis is you're not sick, but I give it to you so you don't become sick. You don't get sick. So this is prophylaxis is a prevention. If you are at risk, like you're a nurse, you are dealing with patients, you're a doctor, you're dealing with patients, and I know that you're working on this unit and you might get this infection, I will give you the antibiotics. I'm not going to wait for you to get the infection and give you a treatment. No, I'll give you a prophylaxis. Okay? Antimicrobials, generally speaking, this is a general term like an umbrella. That's used to call any drugs in general, whatever the origin is, antimicrobials. And then, depending on the origin, we will have categories. But what do you call any one of those? You call it antimicrobial. Any drug that kills the microbes, what should I call it? Antimicrobial. Okay? Irrespective of where it came from, I just call it antimicrobial. Now, depending on where it comes from, I will have three different options. If it is a natural metabolic product of microbes, whether we're talking about bacteria or fungus, like we mentioned it, right? Penicillin, cephalosporin, bacitracine, streptomycin, we mentioned those, right? This is coming from organisms, isn't it? Coming from microorganisms. So I call that antibiotics. If you completely make it in the laboratory or the pharmaceutical companies in the factories, I will call that synthetic, like from scratch. I didn't get anything natural. I know the components, I will make one like this. Okay? We call that synthetic. The third one is you get the natural one and you do some modification. just modification to make it better. I call that semi-synthetic. Is that clear? You get the difference between antibiotic, synthetic, and semi-synthetic. Okay. Generally speaking, when we talk about antibiotics, it can have a limited spectrum, like they work against gram-positive bacteria only. Do you remember gram-positive and gram-negative? We talked about those. Do you remember? Gram-positive bacteria, if I have this antibiotic that work on gram-positive only, I call it narrow spectrum. If it is working against both of them, gram-positive and gram-negative, do you remember what was the difference between the gram-positive and gram-negative? One of them take the stain and the other one doesn't take it. But what's the difference in the bacteria itself? Why it didn't take it? Why it's negative? You have something additional. But all of them have a wall. Now they have additional membrane outside of the wall. Like membrane, wall, membrane again. We did this before, maybe forgot or something, but this is what it is. Why the positive will take it? Because it go to the wall. How about the negative? No, they have additional membrane outside of the wall, so it will not take it, right? If it have additional, it will be negative, yes. So what if you have an antibiotic that can work on both of them, positive and negative? I call it broad spectrum. Is that clear? So narrow spectrum work against gram positive only. Broad spectrum work against positive and negative, plus, here is one important, plus our natural, including, not plus, including our normal flora. So which one kill our normal flora? Narrow spectrum or broad spectrum? Broad spectrum. Is that clear? Narrow spectrum kills gram positive only. Broad spectrum kills positive, negative, and our natural flora. Is that clear? Okay. So if you're taking narrow spectrum, that will usually, it will not kill your natural flora. Again, interaction between the drug and microbes. The drug should kill the microbe. It should be toxic to the microbe, not to us. And we call that selective toxicity. Okay? The problem would be, remember that we're not only talking about, we're saying antimicrobial. We're not only talking about bacteria, right? We're talking about everything. Bacteria, fungus, helminthes, protozoa, viruses, right? We need medications or antimicrobial against each one of those, right? Here is the issue. When it comes to bacteria, the bacteria are prokaryotes, isn't it? So it's different than our cells. So it's easy to use an antimicrobial agent against bacteria because it's not even eukaryotes. But the problem is, if you're working against fungus, protozoa, helminthes, isn't that eukaryotes? Remember that? It's all of this are eukaryotes, right? Prokaryotes are bacteria and archaea, right? Anything else is eukaryotes. So what's the problem with the eukaryotes? They have a lot of common characteristics of our own cells. So it will be kind of hard to use antimicrobial against them. We do have some antimicrobials, but just remember that we have an issue here, right? That there are a lot of similarities between the other types. So it's easy to use antibiotics for bacteria. It's not easy to use antimicrobial for other things, including fungus, helminthes, protozoa, anything else that's eukaryotes. And did you get the idea? Prokaryotes, you can target something in the bacteria specifically, but our cells doesn't have it. Isn't that easy? Kind of easy, right? Like you're targeting the cell wall, for example. Do we have a cell wall? Do we as humans, do we have a cell wall? No, we don't have a cell wall. So that's good, isn't it? You can target the cell wall and you're fine. But any eukaryotes, other eukaryotes, they do not have a cell wall, right? So you need to target the cell membrane. It can target your own cell membrane. Isn't that hard? That's the difference. We will have different ways of the medications to work. They can work on the cell wall, inhibiting the cell wall synthesis. They can work on the cell membrane, breaking down the structure or the function. Structure or function. We will see it. It can interfere with the function of DNA or RNA. Not just the function, it can actually interfere with anything related to those. Do you remember transcription and translation and, right? It can inhibit any of those. It can also inhibit protein synthesis somehow. It can block metabolic pathways somehow. We will see all of this, but you just need to have this idea first. What are you going to work? I'm going to work on any part of the bacteria, for example. Does the bacteria have a cell wall? Yes, we can work against the cell wall. Does it have a cell membrane? Yes, we can work against the cell membrane. Does it have genetic material? We can work against the genetic material, right? Bacteria have ribosomes? Yes. Can we work against the ribosomes to stop protein synthesis so the bacteria die? Yes. Can we block some pathways like reactions and we stop these reactions? We can. So these are the different mechanisms that we will work on to kill the bacteria. Here you will see a lot of names, but I will tell you something here to make it easy for you. Okay, this is a lot. We will need to know a lot of those, but not every one of those. I will tell you the most important. Okay. First of all, in this category, you're working on the protein synthesis. So, which level of the organism are you working on? Which organelle? If you wanted to stop protein synthesis, what part of the bacteria that you're going to work on? Ribosomes, right? So here's giving you some details. I wouldn't really. I just remember that it works on the ribosomes, generally speaking. Okay. And what are the examples of those? I would remember chloramphenicol, erythromycin. I put those in a separate slide. I added a slide specifically for those, just to point out to the most important ones. Erythromycin, chloramphenicol, and these are called aminoglycosides, which is streptomycin and tetracycline specifically important. And you need to remember that it's called aminoglycosides. If you forgot it, amino means amino acid, isn't that protein? So it should remind you. Okay? So this is what I want you to know. So how many of those? What I just mentioned. 1, 2, 3, 4. From this side, from the protein synthesis, I want you to remember 4. Okay? It's good enough to remember that it stopped protein synthesis by working on ribosomes. Good enough. Clear? Okay. Yes. Yes. Chloramphenicol, erythromycin. This is 2. Chloramphenicol, here it is. Chloramphenicol, erythromycin. 1, 2. The other 2 are called aminoglycosides. Streptomycin, tetracycline. Good enough. These are the most important ones. There are others, you can take a look at it if you want to. The other ones will work on the cell wall. And these include a lot of things, but the most important of all are penicillin, cephalosporin, isoniazide. Isoniazide is also known as INH. You need to know this. Penicillin, cephalosporin, isoniazide. I'm sorry. Penicillin, cephalosporin, vancomycin, bacitracin, and isoniazide. So don't worry about those 3. Penicillin, cephalosporin, vancomycin, bacitracin, and isoniazide. Put beside isoniazide, put INH. You will see it. It's coming. Okay. Working on the cell membrane, polymyxin. You need to remember this. DNA, RNA, quinolones, and rifampicin. Okay? So, a lot of those, most of those, but not every single one of them. For this one, sulfa is good enough. For the metabolic pathway, sulfa or sulfonamide is enough. You will see it in the next chapter. It just here, it put it on the bacteria itself, so it might be easier to remember. Okay, and you will see the slides. But again, spectrum. What now the spectrum means? Work against specific type or a specific group of bacteria. Gram-positive, for example. Okay? Broad spectrum, they work on greater range. Positive, negative, but they also kill what? Broad spectrum. What they also kill? Your normal flora. Yes, your own good bacteria. Okay? If this working on the cell components like the cell wall, that will be more of broad spectrum, like this, broad spectrum. Ampicillin, for example, is medium, tetracycline is broad. But broad spectrum usually work on the cell wall. Okay? Drug that target the cell wall. Those who target the cell wall are generally speaking broad spectrum, and it is selectively toxic. Okay, all right. Now the target. Here is what I did. This is an additional slide. It wasn't there. Okay, so I put this to point out to the most important ones, which is it's not few, but not all of it. Okay, these are the most important ones. The ones that work on the cell wall. What do you mean by cell wall? Which part of the cell wall? It usually work on peptidoglycan specifically. Is that clear? When I say, so you need to remember, by the way, let me say this. Each of those medications, you need to tell me which part of the bacteria does it work on and the mechanism of action. You have to remember this. Is that clear? I mentioned in the beginning, this is almost a pharmacology, right? But I'm trying to summarize it as much as possible, okay? It's still pharmacology. You have to know it anyway. Okay, and if you don't know it now, you will know it in pharmacology. So you will need to know it anyway. So if I tell you any one of those that you need to memorize, you have to remember it. Penicillin, cephalosporin, vancomycin, bacitracin, and INH. Which part of the bacteria does it work on? Cell wall. What's the mechanism? How does it work? Peptidoglycan. Is that clear? Not enough to remember cell wall. Which part of the cell wall? Peptidoglycan. What's a peptidoglycan? It's an important component of the cell wall. The most important component of the cell wall. Is that okay so far? For the protein synthesis, just remember those four. In the other slide, it was more than that. It was like 8 or 9. But if you remember those, these are the most famous ones. Tetracycline, streptomycin, erythromycin, chloramphenicol. They inhibit protein synthesis and good enough. And can you tell them the mechanism? How does it stop the protein synthesis? Working on which part of the cell? The peptidoglycan is for the cell wall. This is a protein synthesis. Ribosomes. Yeah. So these 4 antibiotics work on ribosomes. How or what do they do to kill the bacteria? Inhibit protein synthesis. Is that clear? Okay. Next, rifampicin and ciprofloxacin. They inhibit DNA and RNA. So where do they work? Genetic material. They work on the genetic material, DNA or RNA. What do they exactly inhibit? Anything related to those. Anything. Anything. Transcription, translation, replication, whatever it is. The next one is polymyxin, which inhibit the cell membrane selective permeability. Do you remember the selective permeability? The cell membrane should allow certain things of the bacteria. Should allow certain things that are good for the bacteria needed. It's allowed to go in, right? Anything that's bad, it's not allowed to get in, which is good for the bacteria, right? This antibiotic is going to disrupt this. So anything can go in. and this will kill the bacteria. Sulfonamides, which is we usually call it sulfa. It's called sulfonamides. Sulfonamide inhibit metabolic pathway. Which pathway? Folic acid synthesis. So again, this is an extra slide. I put it there to summarize what you have to know, but you have to memorize it anyway. Yes.
For the selective permeability, is that just like what like specific things like not going and stuff?
Here is what's happening. This is a bacteria, right? And this is a membrane. This membrane is selectively permeable. What does it mean? It's open, allow good things to go to the bacteria. And this is good for the bacteria so far, right? Here comes the medication. It will play in the structure of the membrane, so it will not become selectively permeable anymore. It will allow anything to go in. It will die. Okay? So it disrupts the selective permeability. Okay? For those that affect the cell wall, what are these again? Well, we will have some more details, but I'm not going to go to every single word. I will tell you exactly what we have to know, right? So those are working on the cell wall. I mentioned it. Penicillin, cephalosporin, pacitrazine, and INH. Okay? They work on the cell wall. What part of the cell wall? What part of the cell wall? Peptidoglycan. Peptidoglycan. Yeah, you have to remember this. Okay? The first person who discovered penicillin, his name is Fleming. How did he discover it? He discovered it by these types of bacteria secrete something. He took that something and he called it, because the bacteria called penicillium, he called it penicillin. But the name is good to remember. Fleming. Who discovered the penicillin? Fleming. Fleming. Okay? Penicillins work more against gram-positive. Okay? There are, let me say it this way without going on into all the details. Penicillins. There are different types of penicillins. Okay? This is not really pharmacology. I'm not going to go through the details more than that. But just generally speaking, there are different types of penicillins. Okay? The older ones cannot cross the outer cell membrane. So they will not work on the gram-negative. This is the old category. The broad spectrum one, they can. So they can also affect both of them. So there are broad spectrum penicillin and cephalosporins. Okay? Do we have broad spectrum and narrow spectrum from the same antibiotic? Yes. There are different medications under the same name. Like I call this category penicillins. But this is not a medication, by the way. When you say penicillin, I don't mean one. Are we following?
Yeah.
Did you get what I mean?
Yeah.
So penicillin, this is a big category. And then different types, ampicillin, methicillin, a lot of things that fall under the penicillin. Some of those are against positive and some of those are broad spectrum. Okay, look at this. This is what I was just describing. This is a gram-positive. Look at this brown part. And look at this brown part. Do you see something on top of this? You see this green? This is an additional thing. Compare this to this. This is this. You have additional, this green. Yes, this is the outer membrane, and this is characterizing the gram-negative. Did we get this? So the gram-negative again have an additional cell membrane outside of the cell wall. When we say beta-lactam antimicrobials, just remember that we are talking about penicillin and cephalosporin. Good enough. Penicillin and cephalosporin are beta-lactam. What's the beta-lactam? Chemistry. This is the chemistry. Okay? Enough to know. When I say beta-lactam, we're talking about those two, penicillin and cephalosporin. So I mentioned that penicillin is a big category. It's a group of products. It's not just one. Okay? Some of these penicillins are natural. What natural means? You take it from the what? From the microbes themselves. When I say natural, which is the antibiotics, you take it from the microbes themselves. Okay? It can be synthetic, meaning, do we make penicillin in a lab? Yes, we do it. Can we have a third category? Like, can I get that natural penicillin and modify it a little bit? Yes. What do you call this? Semi-synthetic. Okay. So we have 3 types of penicillin. Yes. It can be natural penicillin antibiotic. It can be synthetic. It can be semi-synthetic. And when you talk about this, just know that we have different types. This is kind of too much. Okay. Just remember what I'm just saying. Okay. Penicillin can be natural antibiotics, synthetic, semi-synthetic. And we have different types of antibiotics that fall under the name of penicillin. Okay? Like when you say penicillin G and penicillin V. Where did you get this from? I get it from the microbes. Okay? So this is for the natural. Semi-synthetic, like ampicillin and amoxicillin. And this is broad spectrum. And some of them are this is semi-synthetic, and some of them are synthetic completely. Okay? They notice something here. Okay, let me emphasize this. If you notice, I'm not going through everything. Here is what I want you to know. Penicillin, what should I know? Number 1, it's beta-lactam. Together with the cephalosporin. Both of them are beta-lactam. Number 2, both of them work on the cell wall. Okay? Number 3, penicillin is a big category. We have different types. How are you going to divide the different types? It can be natural. It can be synthetic. It can be semi-synthetic. Am I being clear so far? Okay. The semi-synthetic one are usually the broad spectrum. Okay? Because simply you modify the natural one, which were more against positive, you modified it, so it worked against negative as well. Is that clear? Okay. Here are the 2 issues with the penicillin that we need to understand. Number 1, it's very famous that some people have penicillin allergy. And I think we all hear about it all the time. So this is number 1 issue, penicillin. And the problem is not in the penicillin itself. It's in the individual who have this allergy, right? Do you guys remember the hapten or not? Hapten? Hapten is half antigen. The penicillin is hapten, meaning it's half antigen. So it can work on, if you have allergy against this penicillin, the penicillin will act as a half antigen. And it might lead to allergy. This is problem number 1. Problem number 2. Many organisms produce enzyme that break down penicillin. Why? We don't know. It just happened. They found it. Some of these bacteria secreted something and they found out that this something broke down the penicillin. They call this enzyme penicillinase. Do you remember ASE at the end of any word? It's an enzyme. So what's a penicillinase? An enzyme that breaks down penicillin. Penicillinase, right? So if that's the case, penicillin, if the bacteria produce penicillinase, what should we do now? They started to play in the laboratory with the different types of penicillin. They come up with those. You don't really have to remember the name, but just know that penicillinase resistant ones. Yeah, like just remember that there are some penicillins Just remember this, okay? Some penicillins cannot be broken down by penicillinase. We call it penicillinase resistant. How did they come with this? They changed it in the laboratory. They studied this. You know how? They got the penicillin and I put penicillinase on it. I see it breaking down the penicillin, right? And then I will study in the lab how exactly is it breaking it down. It will cut in this area. How about if we change so it doesn't cut it? Is that clear? That's it. So they developed some type of penicillin that is resistant to penicillinase. So if this organism is producing penicillinase, I will give you one of those. The one that you need to remember is methicillin only. Just remember this. Methicillin as a penicillinase resistant for a reason. I will tell you the reason later on. Okay? But just remember this example. Are we following? I know this is a lot and it's not easy, but are we following so far? Okay. So this is the penicillinase resistance. Cephalosporin, nothing much to remember about this. I only want you to know that this is also a beta-lactam, but most of it is synthetically altered. They take it just like the penicillin and they change a little bit of it. Why did you do that? Why are you taking this cephalosporin and changing it? To avoid the allergy. Because it's isn't both cephalosporin and penicillin are beta-lactam, right? So penicillinase, the bacteria that secrete penicillinase will break down the beta-lactam. So what can we do now? I will do something to change the beta-lactam that doesn't break down. And that's how they came up with this type of cephalosporins. That they changed the chemistry of the beta-lactam. By the way, beta-lactam is just a ring structure, if you wanted to know. Okay? Good enough to know about the cephalosporin. What do I need to know about the cephalosporin? It's a beta-lactam, synthetically altered to avoid allergy. It has less allergic reactions, and the issue of penicillinase as well. But it's more for allergic reactions. So here is, let me say it from the medical point of view. If I want to give you penicillin, and this is my medication number one, okay, I will tell you, sir, you have this type of infection, I would like to give you penicillin. This is my choice, okay? Do you have allergy against penicillin? Yes, okay. Now I have to give you cephalosporin. That will be my number two if you have allergy. Is that clear? So usually cephalosporins, the modified ones, we use it if you have allergic reactions. I'm not going to give you something to develop allergy. Next group is carbapenium or carbapeniums and monopactam. Imipenem is a broad spectrum that work against aerobic and anaerobic. Aztreonam is a narrow spectrum that work against negative specifically. Okay? Penicillin and cephalosporin is more important, but if you wanted to remember, imipenem and aztreonam, imipenem work against aerobic and anaerobic. Now vancomycin. Vancomycin is a very narrow spectrum, but it's extremely effective against the staphylococcus. Let me say this. Vancomycin have a lot of toxicity, so we don't use it until we have to, unless we have to. Vancomycin is a narrow spectrum, but it has a lot of adverse effects. So if you are a doctor or a nurse or something and you think you should use the vancomycin, you need to think twice. It's toxic. Okay? So if it's toxic, why are you using it? Do you remember I just told you to remember methicillin? This is for penicillinase resistant. they came up with methicillin to avoid the issue of penicillinase, right? Staphylococcus, some of these staphylococcus are resistant to the methicillin itself. What should I do now? Then I have to use vancomycin. So, do you use vancomycin routinely? Of course not. Why? It's very toxic. When should I use it? If this organism secretes penicillinase, why don't you use the methicillin? If it is methicillinase resistant, did you get the idea? And we call that MRSA. MRSA. What's MRSA? Methicillinase resistant Staphylococcus aureus. Methicillinase resistant Staphylococcus aureus. What do you mean? Here's what I mean. Pay attention. I have bacteria. I can use penicillin. This is my first choice. Penicillin is one of the safe antibiotics, okay? Use penicillin. But my bacteria is secreting penicillinase. What should I do now? Use methicillin. What if this organism like Staphylococcus is resistant to methicillin? Also, what should I do now? Vancomycin. Okay? Did you get the idea? So vancomycin should be reserved for MRSA only. Other than that, don't use it. MRSA, methicillinase resistant Staphylococcus aureus. This is when you use it. And just for your information, if you think about it, what is this MRSA thing? Why some organisms, Staphylococcus, produce methicillinase resistance from the abuse of the antibiotics? You're using like penicillin like crazy. They give penicillin for everything. So when they do that, it suppressed the normal flora, and this type came up, methicillinase resistant, changed its structure and function, and it became resistant to methicillin, and this one started to take the upper hand. Okay? Yes?
How long would somebody have to be using penicillin to develop MRSA?
MRSA, it developed already. No, it's not like you take it and you develop MRSA. No, I'm saying how MRSA emerged in the first place, in the history. So it's not for one individual person. It's for a lot of people. Everybody's using it. So it came like, do you remember the natural selection? You know what natural selection means?
Right.
So I have these type of bacteria, and I'm giving a penicillin randomly. Okay? So not to one person, to a lot of people, right? So all of these people are taking penicillin like crazy, right? So what happened is some of the organisms, because you're taking the penicillin broad spectrum one, they suppressed their normal flora. And this type of bacteria, they started to change their structure and developed methicillin resistance. And then started to go from person to person to person. This is just the history. I'm not saying if this is what you understood. I'm not saying how you develop MRSA. No. I'm saying how MRSA in the history. How did they develop? They developed by the abuse of antibiotics. This type emerged. It was naturally selected because it's resistant, stayed, and started to go from person to person to person. Okay? But if the question is, how long does it take to inhibit your normal bacterial flora, not irrespective of the MRSA? How to suppress? It takes like 2 weeks or something to suppress them. And the dose has to be strong enough and broad spectrum. And this is the most important thing. Broad spectrum. Broad spectrum is the one that inhibits your normal flora. And so what should I do now? If I'm using antibiotics and I'm using broad spectrum like for 10 days, 2 weeks, so now my normal flora is gone, right? What should I do now? You can use vancomycin instead, but if you already took the antibiotics and you don't have the normal flora, what should I do now? Yes, when you stop using the antibiotics, it will go back. Yes, exactly. Okay? Bacitracine, where do you think it came from? Bacillus. Is bacillus a bacteria or fungus? Bacteria. And I told you have to remember this. Bacillus is a bacteria, right? Streptomyces is bacteria. Yes, yes. You are going to study and you're going to remember. I'm just trying to refresh your information. Okay? So remember that bacillus is a bacteria. Streptomyces is a bacteria from which we have bacitracin and streptomycin. They come from bacteria. The fungus, penicillin and cephalosporin. Okay? They come from the mold. Penicillium and cephalosporium. This is the fungus. Okay? So bacitracin is another spectrum, and usually bacitracin is used topically. It's a topical agent. You get an ointment, like if you go to it's even over the counter. If you go like you have infection in your skin or something, they gave it to you. INH is used for. Do you remember I told you that every single medication you need to tell me which part of the bacteria does it work and how? INH, how does it work? Mycolic acid synthesis. And it worked for treatment of TB. I put INH here to remind you, you don't have to say isoniazide. They can call it INH for short. Both of them mean the same thing. Okay? But it's used for TB. Microbacterium TB. INH is used for TB. Okay, how does it work? Interfere with mycolic acid synthesis. So what does that mean? It works in the metabolic pathway, developing mycolic acid. Do you guys remember how they work? They work on the wall, they can work on the membrane, they can work on protein synthesis, they can work on DNA, RNA, and they can work on the metabolic pathways. Which part is it? Mycolic acid. The ones that work on the membrane, how do they work? Two different ways. You can either, here is what most of the time happens. Do you remember this? The cell membrane is two layers of phospholipid. Right? If you take out some of these lipids, you're going to break down the membrane, and the cell will die, simply. This is one way. The other way is to change the function instead of changing the structure. How to change the function? Selective permeability. You stop the selective permeability. This is how to work on the membrane. Can you answer this question? I think it's easy. Vancomycin. So polymyxin is one, and I put that in the slide if you remember. The slide that I told you the most important ones. Yeah, polymyxin is one that work on the membrane. And when you say membrane, I'm talking about the lipids, the phospholipids. Amphotericin and nystatin. This will work also on sterol, and sterol is a lipid, but it works on the fungus. Polymyxin is against gram-negative bacteria. Amphotericin and nystatin work against the fungus. It's an antifungal medication. Nystatin specifically is the one if you like have athletic foot or something and you go like over the counter, can I get an ointment for this? Yes, they will give you the nystatin. The next type is the type that work on nucleic acid synthesis. What do you mean working on the nucleic acid synthesis? Meaning anything related to the nucleic acid. Do you remember the nucleic acid, DNA, RNA? What exactly can you affect the nucleic acid synthesis? Any part. You can block the synthesis of the nucleotides in the first place. You can prevent replication. You can prevent transcription. Right? And the example of that is chloroquines. Chloroquine. Okay, good enough to know. Chloroquine. So how does the chloroquine work? Nucleic acid synthesis. Another one, fluoroquinolones. They work against something called DNA gyrase and topoisomerase. This is something related to the replication. Okay, this is a broad spectrum, and CDC recommended that we should monitor the fluoroquinolones, specifically ciprofloxacin. Ciprofloxacin is one of the fluoroquinolones, and there is a lot of resistance now to that. So they say you have to be careful about using this. There is a lot of resistance coming. The same as they said for penicillin. You have to be careful with penicillin. When you say protein synthesis, which part of the bacteria are we talking about? Huh? Ribosomes. You're working on ribosomes. And which ones should I remember? I told you. Tetracycline, erythromycin, streptomycin, and there is one more. Streptomycin, did I say? Yeah, streptomycin. Okay. Streptomycin, tetracycline, erythromycin. Remember that aminoglycosides. Okay? When you say aminoglycosides, this is one that work on the bacteria. Again, this is all in the same slide that I summarized this before. Next one is interfering with the metabolic pathway. You remember the sulfonamides I told you? Sulfonamides? Sulfonamides work on the metabolic pathway. Which part of the pathway? Folic acid. You have to remember this. So here is what I want you to do for the activity. You can do it now, you can do it later, that's fine. Again, when I tell you to do something, it's to help you study. It's not just for the points. Okay? So what I want you to do is, you do the same thing, you do cards, you put the antibiotics on one side, only the ones that I told you, which is in the slide. Just go back to that slide. Okay? In the front, you put the antibiotic. In the back, you put which part of the bacteria does it work on and mechanism of action. Example here, sulfonamides. In the back, it works on metabolic pathways. Specifically, folic acid. That's it. Yes?
So you want us to do it on that slide that had like the summary of the list?
Yes.
Okay.
Take those antibiotics from that summary and you put the name in the front and you put two things in the back. Is that clear?
Yeah.
Two things. You need to tell me which parts. This is one. Number two, mechanism. How exactly? Like you say pathway. Okay, this is generally speaking. This is how does it work. Like this is which part. But to be specific, it's folic acid. I'm not talking about all of this. Look, not all of this.
Yeah.
I just want you to tell me sulfonamides. This is the flashcard, right? Sulfonamide. In the back, metabolic pathway, folic acid. That's it. Okay? And you're going to use these slides to study from. Okay? So by doing this, it's something like this is competitive inhibition. Some sulfonamides, they compete. This is how they inhibit the bacteria, and this is not killing, by the way. What killing means? What's the suffix that means killing? Silent. And what's the suffix that means slowing down or stopping? Static. So sulfonamides are usually static. Why? In this case, they work by competing. Okay? They compete with the active side of the enzyme, so they stop the microorganism by competition. Synergetic effect. Sometimes we use more than one antibiotic at the same time, which we call it combination therapy or multiple drug therapy. Okay? They said, okay, how about sulfonamides and there's another one that work on a metabolic pathway that's called trimethoprim, for example. They said, how about we use both of them together? Why are you doing that? Because one of them is going to stop folic acid, and the other one is going to compete, let's say, on the nutrition available. So if you use both of them, isn't that synergetic effect? Right? You work here and I work here. How about we use both of them together? And the most common example of that is treatment of TB. Okay, when you do pharmacology, you will see that you cannot treat TB with one medication at all. You cannot do that. It's very famous, it's very well known that if you wanted to treat TB, it's a combination therapy. You give them about 3 different types of antibiotics. 3. Why? Because this is very resistant. So I will give you this medication that will stop your folic acid, for example. I will give you this medication that will try to disrupt the cell membrane. And then I will give you this medication to stop the protein synthesis, right? So I'm working on 3 different levels at the same, so they work as synergetic. Is that clear? The multi-drug or the combination therapy, it's used, it works as synergetic. They have synergetic effect, working on different levels. So in case if there is a drug resistance, I'll give you an example of that. What if the TB have a cell wall that's resistant to this medication? And you give it the medication, is it going to be effective? No. Do I know exactly what type of TB do you have? Of course I don't know, right? All what I know is that the TB is a horrible organism. It's very strong and very resistant. So what should I do now? I don't leave it to the chances. I'm not going to give you something that work on the wall and you are resistant. That's not good, right? I will give you 3 different types of medication, work on 3 different levels. So if you have resistance in one of the components, you will not have resistance with the other. Did you get the idea of the multiple drug therapy? Okay, can you answer this? Protein synthesis. What amino means? Amino acid, protein. Yes. So tetracycline, streptomycin, they work on protein synthesis. Which organ? Which organelle? Ribosomes. How about this? Yes. These checkpoints that I'm putting is to emphasize the most important things. Okay, so I put it there to give you an idea what you have to know from the chapter, right? So you cannot skip any one of those. Location and mechanism of action. I think you were outside when I mentioned that. I mentioned that the activity for today is flashcards. On the front, I don't need a lot of details. Here's exactly what I want. You get the flashcards, and you get the names that I put on that slide. In the front, you put the name of the antibiotic. In the back, you put 2 things. Location, which organelle does it work on, and the mechanism, and be short. Okay? Example. In the front, I put sulfonamide. In the back, which part? Metabolic pathway. Mechanism, folic acid. Folic acid synthesis. Stop folic acid synthesis. That's it. Okay? Here I put, just to make it clear, here I put penicillin. Okay? Beta-lactam, that would be good. Penicillin, beta-lactam. This is the front. What should I put in the back? Cell wall, peptidoglycan. Okay? Which antibiotics? The one in the list that I put for you, which are the most important ones. Okay? Okay. So this is for the antibacterial treatments. We cover the antibacterial now. Okay? How about the antifungal? nothing much to know about the antifungal, but you need to know that both fungus, protozoa, helminthes, all these three are eukaryotes, isn't it? It's eukaryotes. What do you mean by eukaryote? Meaning it's kind of similar to our cells. So a drug that's toxic to the fungus, it can be toxic to us. So the selective toxicity here is not as good as the selective toxicity of the antibacterial. Is that clear? Is that clear? Did you get the idea? Why? Because these are eukaryotes. So what? There are a lot of similarities with our cells. So if it is toxic to the fungus, it can be toxic to our cells as well. That's why it's not routine. It's not routine to give patients antifungal. If you ever notice, most of the time they use antifungal local. They put it on the skin, right? Like how many times did you hear that this person is taking tablets or capsules as antifungal? That's very rare. Usually we hear about people taking antibiotics, right? Just antibiotics. But taking antifungal systemically, that's kind of hard. Why? Because it will be toxic. You cannot avoid. If you have to choose, let me give you an example here to give you exactly what I mean by this. If this patient having AIDS, okay, AIDS, and his immunity is really suppressed to the extent of he's having fungal infection in the lung, okay, you will tell yourself, okay, I'm not going to use the antifungal because it can be toxic to our cells, right? The patient will die. Literally. The AIDS patient will die. Well, I will use the antifungal. But it's toxic. Yes, he's going to die. What should I do, right? It can have some toxicity, that's fine, better than dying. But if you are a normal person, you don't have AIDS, you don't have any immunosuppression, should I give you the antifungal systemically? No. And did we understand why? Okay. How does the antifungal work? The first type will work on the membrane. Does the fungus have a wall? The fungus have a wall? It has a membrane, but does it have a wall? No, only prokaryotes have a wall. Don't ever forget this. The most important two things that I want you to remember. Prokaryotes. We have a cell wall. Okay? We have a cell wall. Only prokaryotes. They have a cell wall. And they do not have nuclear membrane. Is that clear? And they do not have membranous organelles. This is prokaryotes. One more time. Prokaryotes. What's the most important about them? Number one, they have a cell wall. Prokaryotes have a cell wall. Does the eukaryotes have a cell wall? Most of them no. Number two, they do not have nuclear membrane. They do have genetic material, not a membrane. Number three, they do not have membranous organelles. They only have ribosomes. Is that clear? So if you're talking about fungus, do you have a cell wall? Fungus? No, it doesn't have a cell wall. Do we have a cell membrane? Of course, any organelle or any organism have a cell membrane. The optional in the prokaryotes only is the wall. Okay? So how does this work? Of course, we don't have a wall, so we are going to work on the fungal membrane. Macrolides, for example, amphotericin B and nystatin. Okay? Nystatin, this you will see it over the counter in any pharmacy. Like for athletic foot or something. The other one, if you have something like ringworm, do you remember the ringworm? It's a type of tinea, looks like a ring shaped, and this is kind of stubborn. It will stay for longer time. They can use this graziufoldine And the problem with grazosulfine is it's nephrotoxic. So they don't try to use it unless they have to. Like if it is not, nothing is working and it's getting bigger, what should I do now? You can use it for limited time. Not to the extent of getting nephrotoxicity, just little time. The next is antiparasitic. Antiparasitic, parasite or antihelminthic. It's the same thing, okay? Antiparasitic, antihelminthic. I'm sorry, no, antiparasitic including antihelminthic. Others are antiprotozoal. So remember that the parasites that we need to know will include protozoa, will include helminthes. And those are eukaryotes. So again, you are going to target something in the eukaryotes. Most commonly, the membrane. You can take a look at this. I mean, you don't have to memorize everything here, but take a look at it. Just remember that these are eukaryotes and they do not have a wall. But you can take a look at it, like anti-malarial, like quinines, for example. Antiprotozoal metronidazole, or metronidazole. Flagyl. Did you hear about flagyl before? Flagyl is something that if you go overseas, this is like almost classic. You go overseas and you have this abdominal issues and you have diarrhea, they give you that flagyl all the time. Because if this is a food or drink that's not clean enough, it will have some of the protozoa. Antihelminthic, they work on the metabolism. Okay? And these are examples, you can take a look at it, but when the medication is important, I focus on it. Okay? If the name is important. So other than that, take a look at it. Okay, antivirals. What was the issue with the helminthes, with the protozoa, with the fungus? The issue was that these are all eukaryotes, right? And what's the issue with that? It's kind of similar to our cells, right? How about the virus? What's the issue of the virus? The virus uses the metabolic machinery of the host. Do you remember when we did the virus? Isn't the virus is obligate intracellular? Do you remember this? It enter the cell, occupy the cell, occupy the nucleus, and use the cell machine to replicate itself. Do you remember the activity that I told you to do? So this is the issue. So how can I target them if they are using our own machine? Like you're going to stop the protein synthesis. Well, it's working for the virus and for us as well. What should I do, right? So because the virus is working, is using our machinery, or the machinery of the host, the antivirus is very limited. But generally speaking, you can block any step of the viral cycle. Do you remember the viral cycle, the activity that you did? Do you remember that when I told you like do a cell, and the virus is coming to the cell, it's attaching, it's uncoating. Remember this?
Yeah.
So any one of these steps can be targeted. Like, can you block the penetration? Yes, they penetrate. They penetrated already and they occupy the cells. Can it block the replication, transcription, translation, any one of these steps? Yes. Acyclovir, for example, is used for herpes. Ribavirin, it's also another antivirus. AZT, this is something that I want you to remember. Okay, so you see the last three letters here? VIR, right? VIR. When you see this, it's an antiviral. Okay? But I want you to remember the AZT. AZT. The mechanism of action of AZT. You can add that to your list. Okay? AZT, it works on the metabolic pathway, but specifically it's a thymine analog. It interferes with DNA synthesis. Remember the AZT in details, and just remember acyclovir for herbicides. Okay? So far, how can I use antiviral? I can use it to block the penetration in the first place, to prevent the virus from getting in, right? The virus is in. The virus occupied the nucleus. The virus is using our machinery. What should I do now? You can try to block the replication of the virus, the transcription of the virus, the translation. You can use nucleotide analogs like acyclovir and AZT. AZT is analog to thymine. What does it mean, analog to thymine? Like if you are doing the transcription and you're using thymine, you will take AZT because it looks like it. You're fooling them. Do you understand the idea? Both of these. You know how these medications work? These are analogs to nucleotides. Do you remember when we talked about the genetics? When we talked about how the transcription and translation happen? Remember that you take A and then T and then C. Remember this replication? Put the bases and put them beside each other. Do you guys remember this? So AZT, for example, here it's a thymine analog. Acyclovir, you don't have to know exactly what does it look like, but it looks like one of these nucleotides. So if you're doing the replication and it's time to take thymine, right? I need thymine to put it here. You see AZT will take it instead, and it will stop you. Did you get the idea? Like if you're building this wall, okay? And you're using bricks. I'll give you this brick. It looks like your bricks. But if you use it, it's going to break down the wall for you, okay? So I'm working around you. I give you something that looks like thymine. Use it, and it will disrupt the DNA for you. Did you understand the idea? You don't understand it or not? Okay, that's good. That's good to tell me, right? Okay, here's what's happening. Do you remember ATCG? Okay, so in order to replicate, you need to do this. Here is the DNA. Okay, and you have these. Okay? I'm going to replicate. I need a copy of this. So I'm going to do like A, T, C, G, right? I'm taking the A, and then I'm taking the T, I'm taking the C, I'm taking the G. And then again A, and now instead of taking the T, I found this medication, AZT. Looks like the T. So I will take it and put it here instead of the T.
Is it like a substitute?
Yes, it looks exactly like the thymine. So if you're going to use and you put the T, next time, what is the T? You see this. Oh, I think this is the T. You put it. Okay? And then you go like A, C, A, T, C, G, and it's time to take the T again. This time you take the AZT. Putting the AZT in the middle, it's not actually thymine. It looks like it, but it is not. So it's going to disrupt the DNA, and the DNA will break down. Did you get the idea? Okay. Always feel free to ask about anything, okay? If it is not clear. The other thing is it can prevent the maturation. Like protease inhibitors, for example. Protease inhibitor, when the viral particles start to maturate, do you remember when you replicate the DNA or RNA of the virus and then you put the capsid on it, which is protein, remember this? In order to modify this, you're using some sort of protease to maturate, and then the virus, when they mature, they leave the cell. Do you remember this? As it is maturating, you can use another medication like protease inhibitors. They work for the HIV so that the virus is not going to maturate. Did you get how to target the virus now? Preventing them from entering, preventing them from working on the DNA and RNA, or preventing them from maturating. Yes?
So like with HIV, like if someone has it, like they're not cured, like it just keeps like it from preventing them.
That is a very good point. Yes, it does not cure.
Yeah.
The HIV is still there, but it's trying to, it did the first part, okay? So here is the HIV, it entered into the cells already, okay? and then it's occupying that nucleus. It is duplicating, and it's trying to maturate to leave the cell and go to another cell. It does not maturate. So you're just limiting them instead of occupying other cells. Okay? Unfortunately, there is nothing that can like wipe off. We don't have that. Some other medications, like medications for influenza, amantadine, ranitidine, they discontinue that because there is a very or an increased resistance to those medications. They stopped it completely. So when we see that there is a great resistance to a medication, we stop the medications. Now they have Tamiflu. Did you hear about this before? It's very famous, Tamiflu. They used to use those, but stop. It's not working anymore. And you don't have to remember the names. Just remember that these are old medications that's not used anymore. Tamiflu is still used, only in the beginning. If it is not in the beginning, just let it go, and it will go away. It will heal by itself, or it will go by itself. So these are the different steps. You can prevent the attachment. You can prevent them from entering. If they entered already and it's going to the nucleus, you can stop them here. You can stop the translation, and so you can stop the maturation. So you can stop any one of these levels. Okay? Anti-herpes, like I told you, only acyclovir. So nothing more to know. Just remember that acyclovir work against herpes. How? Mimic the nucleotide. It looks like nucleotide. That's it. Good enough to know. Okay? Other medications against HIV. AIDS. There are some medications for HIV or AIDS that we call it the antiretrovirus. Antiretrovirus. HIV itself is a retrovirus, and it used something that's called reverse transcriptase. I don't know if you remember that or not. But HIV is an RNA virus, right? Being an RNA virus, how does it control the DNA? They have something called reverse transcriptase. What does it mean? The normal transcription is you make RNA from DNA. Is that clear? What's transcription? You make a copy from DNA, and this copy is RNA. Clear? What if you do the opposite? Can I make DNA from RNA? It can be done. It's kind of hard, but there is something called reverse transcriptase. So what if I give you that medication against reverse transcriptase? Does it work against HIV? Yes, it does. This is another type of medication. Interferon. What's the interferon? Nothing much to know about the interferon, but you need to know that interferon for viral infection. What does it do? Interferon, the name comes from, it interferes with the viral replication. It interferes with the viral replication. They use it specifically for hepatitis C. Okay? They have other therapeutic benefits. You can take a look at it if you want to. Reducing the symptoms of the colds. It's slow down some types of cancers. Slow down only. It's not a treatment. Slow down. But can we use it as a treatment? Hepatitis C. This is what I want you to remember. Hepatitis C. So interferon. What do we need to know about interferon? It interferes with the viral replication. Example, hepatitis C. There are other things. But this is the most important. So you can take a look at the other things as well and the other uses, but this is something that you cannot forget. Now, drug resistance. What's drug resistance? Drug resistance is some of these organisms developed resistance somehow, okay, to adapt to the environment against them. Like you're giving them the antibiotics and they are trying to survive. What should I do now, right? They can become resistant. Most of the time, just let me say it this way, these organisms are primitive enough. They are not smart enough to like understand this is an antibiotics and this is what I need to do. No, it doesn't happen like this. Most of the time it happened accidentally. Did you get the idea? Get what I mean? They don't like think about it. It just happened. Okay? Spontaneous mutation. Okay? Like you're giving me a treatment that work on the wall. Is that clear? Penicillin, for example. It work on the wall against peptidoglycan specifically, right? So just for some reason unknown, spontaneous genetic change happened, and this genetic change changed the structure of the peptidoglycan a little bit. Now penicillin is not working anymore, right? So those who develop this criteria will be naturally selected to stay, and other ones will be killed. Is that clear? Another type, they found that this type of bacteria secrete chemical. We don't know why. They secrete chemical, and this chemical is breaking down penicillin, which is penicillinase, right? So these bacteria that secrete penicillinase will be naturally selected, and others are going to die, okay? And they are going to increase, and that's why we have a lot of resistance right now, because those who genetically drifted or those who secrete something for some reason are going to survive, others are going to die, so these are going to flourish and increase in the number. So how does it happen exactly? You need to know this. It can be a spontaneous mutation. What does it mean? Meaning we don't know. It's just the genes changed for some reason, spontaneously. We don't know. Or maybe they got a different gene from other species. Do you guys remember the plasmid? Something happened and it takes this gene from here and transform it to another bacteria. It just happened. So transforming or acquiring new genes. Transferring resistant factors. This bacteria have resistant factor, and plasmid take it from there, send it to another bacteria. Now the other bacteria is also resistant. Okay? So they acquired new gene somehow. Like this. Do you guys remember this? The conjugation, plasmid taking the gene and inserting it into the other bacteria. Drug inactivation. You're giving a treatment, which is penicillin. Some of these bacteria secreted something, an enzyme, that's called penicillinase. This is drug inactivation. Penicillinase is going to inactivate your drug, which is penicillin, right? Why that's happening? It happened. They secrete something and it worked. Okay? And they call that something which is an enzyme, they call it penicillinase. The other thing is working on the permeability. Decreasing the permeability to the drug itself. And here's how it happened. Look at this picture right here. This is normally what's happening. The drug go and attach or interact with receptors, and it will be allowed in. These type of bacteria, they drifted, they changed, and they changed these receptors. So when the medication come, when the drug come, it will not be able to interact anymore. Okay? And this is a change in the membrane itself. And this is actually what happened with MRSA. Do you remember the MRSA? Methicillin resistant Staphylococcus aureus, how do they become methicillin resistant? You're giving them methicillin, and then they change the wall. Methicillin is type of what? Which type? Which category? Which big category of antibiotics? Penicillin. It's one type of penicillin. Okay. So methicillin is a type of penicillin, and you're giving this medication to the Staphylococcus aureus. Okay. So the Staphylococcus aureus, what they do? So this is the mechanism that's used for MRSA. Is that clear? How did that happen? Staphylococcus aureus, they changed the membrane. They changed receptors in the membrane. So now, when you give methicillin, it will try to interact with receptors on the wall. It will try to enter, but it cannot do it. Do you understand this? Always ask any question you want. If it's not clear, just tell me. Okay? Is that clear? If not, just say no. I will explain it. Is that clear? Okay, that's always good to ask. Okay? So here is the membrane, right? This is the Staphylococcus. Remember Staphylococcus looking like this?
Yeah.
This is the Staphylococcus, right? So here's the Staphylococcus. Here's what's happening normally. I give you antibiotics, penicillin. You have this receptors. So penicillin come, interact with the receptor, enter, kill it. This is normal. For some reason, some of these Staphylococcus, they changed the receptors somehow. So the receptor now, instead of looking like this, so let's say it looks like this. Okay? So look, here is the penicillin coming. Does it fit here? It does. It does fit, and then it gets in. So somehow they change the receptor, and now it looks like this. Okay? So penicillin is coming. No, you're not allowed in. Okay? So become resistant to methicillin. I'm talking about methicillin now.
Is that if it's like taking too much? Like,
Yes.
oh, okay.
You're taking too much methicillin, like people are being prescribed methicillin all the time for Staphylococcus. So it happened that some of these Staphylococcus were able to change the receptors on their membrane. So now they are resistant, and they are not going to be killed. Others are going to be killed. Those are going to stay, and because they stay, they are going to replicate. They are going to increase their numbers. They will take over. So now you have to change. You're not going to use, if that's the case. But is the mechanism clear?
Yeah, that makes sense.
Here is another thing that they found it, which is very weird. They found some organisms, some bacteria, are able to pump out the antibiotics. Pump it out. So the antibiotics gets in. Look at this. Look at the picture. This is a medication, right? Interact with the receptor. This is another mechanism. You're not changing the receptor. It's okay. You interact with the receptor and you get in. And then I'll pump you out. You get in, I pump you out somehow. Some bacteria can do that. How? We don't know. They developed this somehow. Genetic changes, we don't know. But they acquire this ability. If that's the case, they are resistant. Some of these bacteria are have multi-drug resistant pumps. Some of these, okay? Not only one medication. They have multiple. They can pump out different medications. Like you give them penicillin, it interacts with the receptor, it gets in, but then you pump it out. And then you give them cephalosporin, it gets in, and then you pump it out. Some bacteria can do that. Okay, which is called the multi-drug resistant pumps. So what's happening here is you give them medication, it enters, and you pump it out. If it is multi-drug, it can deal with different drugs. At any time, if you guys have a question, please let me know. All right? Everything should be clear enough. I mean, the chapter is hard enough. So I'm trying to explain it as much as possible. You have a question, just let me know, so it will be easier to study. Okay? Other ways to acquire resistance is to change the binding site. Example, tetracycline. Tetracycline work on the ribosome, right? I told you to memorize these medications, and you're going to do the activity for it, okay? So tetracycline as an example of protein synthesis inhibitors. It go to the ribosome, and act on the ribosome, stop protein synthesis. How about this? What if I change my ribosomes, the way it looks, or the site that you bind to? If you're going to bind to this site, look at this, I have this site, and you are designed to go into this site, right? I'm going to change it so you cannot bind to it. So if you change like here, it becomes circle. Look at this. Can you fit in here? No. So can you change the binding site? Yes. Instead of being triangular, so the medication can fit in, I'm going to make it like this. On the ribosome. So when you come to the ribosome, you will not find what you're supposed to find, which is your binding site. Using an alternative pathway, this is another way to acquire a drug resistance, right? So here is the pathway. And when we say metabolic pathway, means reaction after reaction after reaction, okay? So we have component A that will become B, C, D, E. So this is the way to produce, let's say, folic acid, okay? From one, irrespective of the detail. You do step after step after step after step, and then until you make folic acid, right? So if I give you a medication here that stops the folic acid, it just happened that some bacteria were able to do an alternative pathway. You are stopping this pathway, okay, I'm going to do it in a different way. So you give me the medication, it's not going to work. And this is another way of doing the resistance. And remember the sulfonamides? Sulfonamides. Sulfonamide will block like folic acid. Okay, you're going to block the normal pathway. I will do another pathway. Can you answer this? So others are correct, right?
Yeah.
They can stop the synthesis, they can stop the maturation, they can block the receptors. Yes. So this will bring us to the natural selection, and natural selection is simply those of the microbes that were able to develop drug resistance are going to stay, are going to survive, are going to replicate, increase their numbers, and those that were destroyed will disappear time after time. With time, they are going to disappear, and those better ones that are resistant are going to stay. Natural selection. The interaction between drug and host. How the drugs are going to affect the host. The host is most likely, we're talking about us, humans. Okay? How is it going to interact with our cells? The problem is they found that about 5% of those taking the antimicrobials might have side effects. What are the side effects? Side effects include direct damage if taken in big amounts. It can include allergic reaction. It can also disrupt the normal flora, leading to superinfection. What's superinfection? Here's a superinfection. I have infection, right? I have pneumonia. You're giving me broad spectrum antibiotics, okay? Broad spectrum is going to kill gram positive, gram negative, plus what else?
Broad spectrum, your normal flora.
You're going to call it to kill your normal flora. So if you have harmful bacteria, they found they will the harmful bacteria will find the field empty, right? They don't have competitors. They will take over and they cause super infection. So the infection is what happened in the beginning, that you're giving antibiotics against. And then another one came because you disrupted the normal flora, and we call that super infection. Like Clostridium difficile, for example. This is very famous. You take the antibiotics for some time, and then after like 2 weeks or something, I have severe diarrhea. Can you tell me why I get this diarrhea? I will tell you that broad spectrum kills your natural flora. I eliminated the competition for this type, Clostridium for this type, so it takes over your colon and it causes diarrhea. Did you get the idea?
Yep.
For super infection? Allergic reaction does not happen from the first time. Let me say this piece of information. I have penicillin allergy. The first time you give me the medication, I will not have the allergic reaction. I will develop my allergic components ready for the next time. Is this point clear? So allergy will develop next time, not the first time. Okay? Other toxicities, I don't know if you know that or not, and it's not even important, but just for your information, if you take Tylenol, what will happen if you give me this bottle of Tylenol and I take all of it? What will happen? It will damage my liver. What if you give me like this bottle of Advil? Can I, if I take the whole thing? Like people can commit suicide by this, right? You take the whole bottle. Can the ibuprofen, like the Advil, this is good. Did everybody take it? Yeah, but don't take the whole bottle, right? If you take it, it will destroy your kidney, specifically. Okay, so it can be liver toxic, hepatotoxic, can be nephrotoxic, and so on. If this is an allergic reaction, what's the most common one for the allergy? What's the most common antibiotic that have allergy? Penicillin. So if that's the case, penicillin will work as antigen. To be more specific, it's not a complete antigen, that's some information. It's more of a hapten. Okay? But it will work as an antigen. And you are going to develop allergy. Allergy can be hives. You know what's hives? Itching and sneezing. So you can develop hives, and this is the mild form, but it can go to anaphylaxis as well. You know what's the difference between hives and anaphylaxis? This is a mild allergy, this is severe allergy. Anaphylaxis is you're suffocating, right? You have bronchoconstriction and drop of the blood pressure. So it can go to that extent. Most allergies will be against penicillin. Okay? Another side effect is the discoloration of the teeth, tetracycline. And that's why do not ever give tetracycline to children with growing teeth. It will mix with the teeth and it's going to discolorate or make discoloration, it will cause discoloration of the teeth. This is something that's well known for tetracycline. The way I remember it, if that's going to help, tetra means 4, right? Tetra means 4. So I remember tetracycline, it will make 4 colors of the skin. Tetracycline, coloration, 4 colors. Okay? It's discoloration if you're growing teeth, not us. Children who have the growing teeth, right? Again, this is the super infection. How does it happen? You're giving a broad spectrum, killing the normal flora, no more competition for Clostridium difficile, for example, that will cause diarrhea. So diarrhea is a super infection. When you consider antimicrobial drug, I think we talked about this before, you need to know the nature of the microorganism first, most of the time. So they do like a throat swab, right? If they think that you might have strep throat or something, they take a swab, right? While they are taking a swab, they need to know exactly if you have streptococcus or not. If you have it, I'll give you something specific for that. So it's always good to know what type. Practically speaking, we don't do that all the time. Like You don't, like, every time you go to the doctor, they will tell you, okay, we need to find out what kind of organism is it. No, it doesn't happen like this. But if it is something that's that as bad as Streptococcus or Staphylococcus, it's better to know. The medical condition of the patient. Can he afford taking that medication or not? Or which medication is good for him in that case? The sensitivity of the organism to the drug. Is this organism sensitive to that drug or not? What determine the antimicrobial activities? What are you treating, which is a microorganism? The length of exposure. How long are you going to take it, and how long you were infected? How long did you have this infection? How strong the medication is, and the organisms that are being treated. Factors that influence the action are number of microorganisms, the type of microorganism, even the temperature and pH. They will determine how effective the medication is. And the mode and dose of the agent. Are you taking this by mouth? Are you taking this IV? Of course, the IV is more effective, right? IV is more effective. It goes directly to the blood. So you're taking the whole dose. And what's the dose? Am I giving you half a gram, like 500, or I'm giving you a gram? Obviously, the dose will make a difference. Now, to test the susceptibility, what's the susceptibility again? Sensitivity. What do you mean? I mean, I need to know if this organism is sensitive to that antibiotic or not before I give it to you. Is that clear? So this will give us 3 different ways to know if you have resistance or not. I want you to test the sensitivity. You need to tell me, are you sensitive or resistant? Is your bacteria or microbes, is it sensitive? You know what sensitive means? Sensitive, when I say this bacteria is sensitive to the antibiotic, means the antibiotic will kill it. Okay? So I would like to know if this microorganism, if this bacteria is sensitive to our medication or not. Is that clear? So tell me if it is sensitive or not. If it is not sensitive, it means it's resistant. Right? Did you get the idea? So I wanted to know if it is sensitive or resistant. How to know? 3 different ways. Number 1, Kirby-Bauer disk diffusion test. Number 2 is E-test. Number 3 is tube dilution test. Okay? What are these doing? Testing the sensitivity. What do you mean? It's telling me if this organism is sensitive or resistant. Is that clear? This is the use of all these. But when we come to the tube dilution test, it's giving us something that's very important to know, which is the MIC, the MIC, which is the minimum inhibitory concentration. What is that? And by the way, this is something that pharmaceutical companies, they have to do. This is part of their production. Before taking the license, by the way, if they go like to the FDA and say we need to provide this medication, they will tell them, give me the MIC first. Okay? What's the MIC? Minimal inhibitory, or the minimum inhibitory concentration. Tell me what's the minimal concentration that can kill the bacteria, so we can use it. Like if a half a gram is good enough, we don't have to use a gram, right? You need to tell me exactly what's the minimum that can inhibit the bacterial growth. In this case, tube dilution test, microbiologists, they take a serial dilution of the antimicrobials, okay? And they put it like this, 5, 6, 7, whatever. They put different dilutions, and then they put standard amount of the pathogen, and see which one is the minimal that will be affected. I will show you the picture, will make it more obvious. But generally speaking, it looks like this. Look, if I have this, here's a tube. 2, 3, 4, 5. Okay, these are 5 tubes, right? And I'm going to put here 1 gram, 100 milligram, 200. 300, 400, 500. Okay? 100, 200 of what? Of the antimicrobial, of the antibiotics. Okay? And then I'm going to put here the same amount of the pathogen from the patient. I put this, exactly the same as this, exactly the same as this, this. Okay? So I will see this one is killing the bacteria. So this one is good, but this is very high. This one is killing the bacteria. Okay, this one is good, but high. This one is killing the bacteria. This one is not killing the bacteria. Which one should I use? Yes, number 3. Did you get the idea? I can't use 100 or 200. It doesn't kill the bacteria. Which one is the minimum that kill the bacteria? It's this one. Should I give you 4 or 5? Why? Why give you something that I can give less and it's going to do the job, right? So this is the MIC, the dilution way. Do you understand it? You call it the tube dilution test. And this is how they do it. For the Kirby, yes?
So are they doing that, like, the nursery, whatever, are they doing that before they prescribe the medication?
No, this is the pharmaceutical companies do that.
Okay.
And they put it on the prescription. If you open the medication, you will see this. You'll see the MIC. They have to do it before getting authorization to produce the medication. Like the FDA will say, what's your MIC? I don't know yet. No. Of course they know, but I'm just giving a scenario. Okay, you have to tell me. So this is what the pharmaceutical companies do. In the beginning, they will have to put like this, and when it comes to the MIC, what's your MIC? 300. Okay. Then I will not give 500. But can I give 100? No, it's not going to do the job. Do you understand it? Okay. The other type can also work is the Kirby-Bohr test. This is a test that's simply using the size of the zone around the organism to tell me if this microbe is susceptible or resistant. And instead of doing this, there is another way, which is the Kirby dish or the Kirby test. And we simply do it like this. Here is our dish like this. Okay? And I'm going to put different microbes here. It's the other way around. Instead of changing the doses of the antibiotics, I'm going to put antibiotic here. Okay? And I'm going to put this pathogen here. Another one here. This is 1, 2, 3, and 4. And here's what I'm going to notice. Here's what's happening. These are pathogens, right? Different pathogens. And the antibiotic is around them. And the antibiotic is going to work against these organisms, right? And then it will create a zone around them like this. Which one is the biggest zone? Which one? 4, right? So number 4 is the biggest zone. What is that zone? This is the effectiveness of the antibiotics. This is how much it is surrounding and it is inhibiting. So the larger the zone, the more sensitive it is. Okay? Did you get this? So no, I'm not going to give it to this, to number 2. This does not work well on number 2 because the zone here is too small. This zone is really big, meaning the antibiotics is working really good, making all of this, surrounding it, and working on it and inhibiting it. So the greater the zone, the more sensitive it is. Can you tell me which one of these organisms is the most sensitive to the antibiotic? Yes. Which one of those? 1, 2, 3, 4. Which one is the most sensitive to the antibiotics? 4. So that should give it to 4. Should you give it to 2 Of course not. This is the smallest. So it means that number 2 is really resistant to that antibiotics. I will not give the antibiotics. And they do this in the pharmaceutical companies as well to tell you which organism should you use it for. Did you get the idea? Like, and this is sulfa, and it is working on this. On the E. coli, for example. So we'll tell you, please use sulfa for E. coli. And you say, okay, can I use it for staphylococcus? No, it doesn't work again. You need also, microbiologists should avoid the contaminants. Microbiological contaminants is other microbes that are not supposed to be there. So if you're using specific microbes, you need to avoid the possibility of having contaminants, which are other microorganisms are not supposed to be there, unwanted. So here is Herbivore test. See the zone of inhibition here? This is very small, right? This is almost nothing. So I'm not going to use it for this one, right? Which one should I use it? Which one of those, for example? I should use it for this one, right? Because look how the zone of inhibition is really big. It means the antibiotic is really effective against this one. But if you look at this one, should I use it for this? Of course not. The zone is too small, so I'm not going to use it. How about this? This is something that we found. How about if this is almost equal, right? Almost. So what should I use it for? Like, is it okay for both of them? No. This one, the zone, still have some of the microbes here. Okay? So this zone is not perfect. Use it for this. Okay? Generally speaking, here's what I want you to know. If we're talking about this Kibri test, the bigger the zone, the more sensitive the organism is. That's it. The bigger the zone, the more sensitive. The smaller the zone, the more resistant. Is that clear? That's it. E-test is more of a diffusion test. You're using, it's very close to the same thing. You're using different types of antibiotics like imipenem and cefazidine. Cefazidine is one of the cephalosporins. Irrespective, this is not the issue. The issue is how much diffusion are you going to do? Okay, you're diffusing more, it means it's less effective. This is the dilution test. Look at how the doses looks like. This is a control dose, nothing is here. And then more. I'm going to pick this one. Okay? You see how this one is clear? Before that, it didn't count. Here it counted, right? And here it counted. Here it counted. Which one should I use? This. Because this is the MIC. This is the minimum. If this is working, if 1.6 is working, what should I give you 3.2? Because it's working. Yes, but I can give you list those and it's still working. Did you understand the idea? This is the MIC with the dilution test. Just the same explanation in a different way. Now there is something called therapeutic index that you need to know. What's the therapeutic index? Therapeutic index is an index that describes the ratio between the dose of the medication that's toxic to the minimal effective dose. Okay? Like if I give you 2 grams, this is the minimum effective dose and it's going to work. If I give you 4, 6, 8, that's all okay. If I give you 10, it will become toxic now. It's a relationship between what's toxic and what's the minimum effective. Is that clear? The bigger the index, the better the medication is. Meaning, just think about it this way. If I give you a medication that the minimum effective dose is 2, and it's toxic at 4, is that good? Like if any mistake happens, it's toxic. This is bad, right? But if I give you 2 is effective and 10 is toxic, this is a better medication, right? Because if I give you 4 for some reason, it's not going to be toxic, right? Even if I give you 6. So the bigger the index, the better the medication is. Is that clear? Make sure to understand everything here. It will make it easier. If you don't understand, just tell me. Okay, which one do you think?
The smallest concentration.
The smallest concentration. Strategies to limit the drug resistance. They are like if you wanted to take an antibiotic, you have to have a prescription, right? You can't go get your antibiotics. Why? Because of the abuse of the antibiotics that led to development of huge problem, which is resistance. So what should we do now? The physician should make a good diagnosis and give antibiotic that's good for this specific diagnosis. The patient, this is number one, the patient should take the medication as prescribed and until the whole medication is gone. You can't tell me, I gave you like 12 capsules and I'm telling you to take 2 per day. And then 2 days later you feel good, I'm going to stop. No. You're not supposed to do that. But I feel good. Yes, but you're not treated yet. You feel good, but you're not treated yet. You have to finish every single capsule that I give you. I give you 12 for 6 days. You have to take all 12. You don't even leave one. Okay? This is a compliance of the patient. A shotgun approach is just an approach that you need to understand that they say, okay, well, what should we do now? This patient is having several infections or something and we need to do something about it. So like a shotgun, you're shooting everything. You give a broad spectrum antibiotic just to wipe off everything. And this should be used as a last resort. You're not supposed to do that unless you have to. Like, what should I do now? I have to work something right now. The patient have a lot of infections. Just give him the shotgun. There is a lot of drug research they are trying to find medications with less side effects, medication that we don't have allergy against it, medication that bacteria didn't develop resistance against yet. So this research is going on, but on the long term, there is something that should be noticed. Number one, in order to take an antibiotics, there has to be a justification. Example, if you're having flu, should I give you antibiotics? Of course not. What the antibiotics is going to do? If you have colds, should I give you antibiotics? Of course not. What is it going to do? Nothing. It's just going to create an issue, right? So give it only if you are sure that this is a bacterial infection. We know that colds and flu is a virus, right? What the antibiotic is going to do with the virus? Nothing. Absolutely nothing. Actually, it's harmful because it will cause resistance and it will disrupt your normal flora. This is one thing. You try to use the antibiotic for 1 or 2 types of infections. So doctors and nurses should work together and say, okay, let's use the ampicillin for streptococcal pneumonia, for example. Let's try to use it for this. Don't use like randomly. Don't give like random ampicillin for anything, okay? Try to limit it for specific types. Other things are, you can take a vaccine. Instead of waiting for you to get the disease and give you the antibiotics, why don't you take the vaccine, right? And we have a lot of vaccines. The other thing is, do not give animals and plants antibiotics. They do that. They do randomly. They give antibiotics to the animals. You are going to take it with the antibiotics in it, right? So that should be avoided as much as possible. Okay? So that's it for this chapter.